You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is June 27, 2011, and I'm your host, Dr. Jay Portnoy. Our topic today, headaches. Our presenter is Dr. Jean-Baptiste Le Pichon. He's a neurologist in the section of pediatric neurology at Children's Mercy Hospitals and Clinics. Welcome to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is June 27, 2011. We're joined today, very fortunate to be joined today by Dr. Jean-Baptiste Le Pichon. I probably butchered that with the French accent because I'm not French, but Dr. Le Pichon actually is French. He's a neurologist. He's in the Department of Pediatric Neurology here at Children's Mercy Hospitals and Clinics. He's also done PhD work in neurosciences, so he is truly an expert in neuroscience and neurology. Dr. Le Pichon has agreed to talk with us today about headaches, a very common problem that we see in the allergy clinic. Many people come in wanting to know if their headaches are caused by allergies, and sometimes they are, but most of the time they're not. It's often hard to tell what causes the headaches, but in many cases there are some simple things that allergists can do to manage headaches before necessarily sending them off to the neurology clinic. However, some patients clearly need to see a neurologist. How to figure out when the allergist can manage those patients and when they should see a neurologist is something that we're going to find out about today. So without any further delay, I'll turn the podium over to Dr. Le Pichon, who's going to talk to us today about headaches. So here's the keyboard, and here's a wireless mouse. If you make the, here, let me just get the window, and all you have to really do is to hit the arrow keys, and you can move back and forth. So take it away, Dr. Le Pichon.
Very good. Well, thank you very much for this kind introduction. So it is a pleasure to come and talk to your group about headaches. And really, the way I try to structure and organize this talk is headaches sort of, what do you want to know? What do you need to know? Sort of a first aid for headaches in the allergy and immunology clinic. It really could be in any general pediatric clinic. So the overall organization of the talk, we're going to come back to this slide over and over so that you know where we are in the talk. We're going to start by talking about headache classification. When should a headache require further workup? I think that's a big question that we very often have. Should we get an MRI? Should we get a CT? Should we get an EEG? We'll talk a little bit about nomenclature, just clarify some terms that are often confused. We'll spend most of today's talk on migraine headaches, because migraine headaches is probably going to be the headache that you're going to deal the most with. We'll talk about epidemiology, classification, acute and preventative treatment. We'll then spend some time talking about medication overuse headache, because that is a very common problem that we run into. And we will wrap up with a few of the trigeminal neuralgia, mostly talking about cluster headaches, mostly for the sake of completion. That is probably not going to be a problem that you're going to see in the pediatric clinic. So, starting with headache classification. So, this slide comes in as sort of a disclaimer. Headache is actually an incredibly complicated topic. The official book that everybody uses is the International Classification of Headache Disorder. The second edition was put out in January of 2004. It's over 160 pages long and 200 diagnoses. And this is the typical, sort of like the DSM-4. This is what this is the criteria, so it's not a lot of talk. It is really broken down into three broad categories: the primary headaches, which include 45 different diagnostic categories. We're going to talk about 3 today. The secondary headaches, which include 120 different diagnostic criteria. We'll just have one slide about that so that you're aware of it. And the cranial neuralgia, there are 29 different causes listed. We will talk mostly about cluster headaches and mention a couple of other in passing. So again, the purpose of this talk is something useful that you can take with you and apply in the context of your clinic. So primary headaches. What are the primary headaches? The primary headaches are the headaches that cannot be attributed to any other cause. That would include the migraine headaches, the tension type headaches, the cluster headaches and its relatives, and the other primary headaches, the exertional headaches, hemicrania continua, which is rather rare, hypnic headaches, etc., etc. Secondary headaches. Secondary headaches are headaches that are caused by any other abnormality. So post-traumatic headache is a big issue that we deal with a lot in the neurology clinic. I don't think you're going to see a whole lot in the allergy clinic. Is the topic for a completely different talk, which is something that at Children's Mercy we're actually setting up. We now have a post-traumatic, a group of people who are specializing in post-traumatic syndrome, including Dr. Jen Bickel and myself for neurology, and a few other people as well. We do the neuropsychological testing, etc. It's really the subject of a completely separate talk, which I could review if there was some interest. But a big topic, a very topic that's very much in the news right now. Vascular disease, abnormal intracranial pathology. This would include the typical pseudotumor cerebri and all of the other things that can happen in the head that will go wrong. Substances, CNS infections, obviously, homeostatic disorder, hypertension, thyroid disorders, diabetes, all of these things can cause headaches. Cervicogenic issues, this is the one that everybody always says, oh, he has headaches, it's probably the sinuses, right? And this is probably something that you hear a lot.
Everybody comes in complaining of sinus headaches.
Yeah, everybody has sinus headaches, and the reality is that by the time they get to me in clinic with the migraine headaches, they've been worked up for sinus headaches. They've had CTs, they've had MRIs, and as you all know, if a radiologist reads an MRI and declares the sinuses to be normal, he probably hasn't looked at the MRI. So I think this is another way of saying that every single MRI that you get is going to have some sinus abnormality. So by the time the kids get to me, they have frequently been on multiple antibiotic treatments. I'm not saying those things don't happen. They definitely do happen. But unfortunately, I'm saying that migraine headaches end up being often misdiagnosed as sinus headaches. And then psychiatric conditions can cause secondary headaches. So when should a headache require further workup? I think this is a big question that's on everybody's mind. When should I get an MRI? When should I get a CT? When should I work up a headache? So this is kind of, I like this one. I thought it was pretty funny. But in essence, I think the point this cartoon is trying to make is if it's an obvious migraine, you do not need a workup. You do not need an MRI. You do not need a CT. Really, it starts with a careful history and physical. This is obvious. I think we've heard this over and over and over again, but I cannot emphasize enough the importance of the history, especially the history in terms of diagnosing headaches. You need to get a history of the age of onset of the headaches, the frequency of the headaches, the severity of the headaches, the quality of the pain. Is it throbbing? Is it frontal? Is it lateral? All of these things are going to contribute toward making a diagnosis of either red flags are present or red flags are not present. And so, in other words, if I have a 7-year-old who presents with headaches that have been going on for about 6 months, they initially were infrequent, happening maybe once every other month, and recently they've been starting to happen every 2 weeks. So little boy, he is complaining of bad headaches. He has difficulty describing the pain any more than it hurts a lot. But his mother will tell you that that child is crying when he gets the headache. He stops what he's doing. He will avoid light and loud noises. That is a classic migraine. And one of the things that we're going to talk about is that, the onset of migraine in the younger age, boys are more likely to have these headaches, and they can present as young as 5 or 6 years old, which is one of the big surprises. I mean, I can't tell you how many parents have told me, my child is 6 years old and he has migraines, and the answer is yes. And we treat them and they get better, and the parents love you. So, the point is children can get migraines. Again, what we focus on is it a typical presentation? So obviously this assumes that we all know what the typical presentation are. So after a detailed history, then the question is, are there any red flags? If there are any red flags, and we're going to talk about those in a second, then a further workup should be instituted. And then, if there are no red flags, does this fall in one of the categories of the typical primary headaches? If it does, then just diagnose a primary headache disorder, treat, and go on. You don't need to do any further testing. If it does not, then you need to think about secondary headaches. So here are some of the red flags. Sorry, this is a little bit of a busy slide. This is taken out of an article that was published in Neurology in 2004, which is a really good article. The reference is there for those of you who are interested. But basically, these are some red flags, but really red flags are common sense. So a sudden onset of headache, the classic thing we're taught in medical school is the worst headache I've ever had in my life. It happens all of a sudden. You've got to think about subarachnoid hemorrhage. As a general rule, a sudden onset or a new onset headache that is getting worse, you must evaluate it with an MRI or a CT as appropriate. So say I have a 14-year-old who presents with severe pressure-like headaches that have been going on for the last month and a half. They're constant, they're unremitting, they're unyielding, they're worse in the morning. Frequently they awake with nausea in the morning, and he never had a headache before this. This is a kid who needs an MRI. This is a kid who probably has a brainstem tumor. Okay, the classic presentation of a brainstem tumor is going to be a worsening headache over a fairly short period of time with emesis in the morning, although you won't always get that history. But again, the theme here is there is a gradual worsening. It doesn't fall in the category of a typical migraine headaches. Focal neurological signs. If there is a seizure, obviously you need to get an EEG and an MRI, especially if it is a focal seizure. Some kids, after a seizure, will complain of bad headaches. So they will wake up in the morning because they had the seizure during the night. And they will wake up in the morning and they will complain of a nasty headache, and this happens maybe once or twice a month, and they have urinary incontinence every time, when all the rest of the time they don't have any problems with urinary incontinence. You ought to think about seizures in those cases. And the parents may be missing the seizures because they're having the seizures while they sleep. So this is one case where, again, a careful history is going to make the difference. Papilledema, this has to be part of the exam for every child who presents with a headache. Papilledema is a classic presentation for pseudotumor cerebri, but also sinus venous thrombosis. And any child with pseudotumor cerebri should have an MRI and an MRV for evaluation of sinus venous thrombosis, and should be adequately treated. If you are uncomfortable with the fundoscopic exam, you can always refer them to their ophthalmologist and say, okay, I would recommend that, as part of the evaluation for this, you be seen by your ophthalmologist, and that make sure you specify. You tell the family, make sure that your ophthalmologist does a fundoscopic exam, or in layman's term, looks in the back of your eye. And make sure that most of the families don't know the difference between an ophthalmologist and an optometrist. And you really need an ophthalmologist for that. So just make sure you talk with them about that. And as long as there is no papilledema, you probably don't need to worry about pseudotumor cerebri. If there is any doubt, a lumbar puncture is then indicated, and an elevated pressure over 20 requires treatment. And at that point, you can send them to me, although there would be no problem with starting Diamox while you wait. With pseudotumor cerebri, you really there is no emergency unless the pressure is outrageously high. So a pressure above 20 will be abnormal. If the pressure is outrageously high, then you probably should worry. But typically there is no emergency, so you should not. The problem is over prolonged periods of time, if it's left untreated, they will end up having vision loss.
Remember, allergy offices usually don't do spinal taps, so we're going to be sending them to you to measure that pressure anyway.
And there's no problem. That is a very good referral. So, if there is a question, if somebody is unsure, that is a very good referral. That is a patient that we're happy to see. A headache that is triggered by cough, exertion, or valsalva, and there is a little catch here. Now, if you've got a kid who comes and who tells you that every time they exercise, after the exercise, they get a headache. Now, obviously, I know you will have done your job and have ruled out asthma, but, exertional headache is a form of primary headache. But if you have a child that has never had an exertional headache before, and all of a sudden comes in and tells you that they're having really severe headache with a simple Valsalva maneuver, such as having a bowel movement, you really need to worry and probably should get CT.
Yeah, that's assuming that there's not another obvious explanation. 'Cause 2 weeks ago I had acute sinusitis, and when I would cough, my head would just hurt like crazy.
Right.
But I think that was a pressure change or something.
Right. No, and so that is an important point. So everything I'm going to say today, with primary headaches, that is an essential point. Any other reason for the headache must be ruled out. So this is sort of a catch-22 because I just said, well, if it's a straightforward headache, you don't need to rule it out with any fancy tests. So again, this will depend on your exam. But you're absolutely right. If there is a flaring sinusitis with, nasal discharge, thick purulent nasal discharge, and there is a fever, and obviously that headache could very well be caused by pressure on the sinuses, which then has referred pressure to the trigeminal nerve, which is the same nerve where the referred pressure is coming from in the case of migraine headaches. So the pain can be different to distinguish, which is why people get those two so often confused. And if there is a new headache in a patient with an underlying disorder such as cancer, Lyme disease, or HIV, obviously all of those should be thought about. Okay, so nomenclature. I really like this. Can I use this to have an arrow or no?
Oh, certainly.
Oh, there you go. Is it moving? Oh, okay, great.
You just have to get it started.
Okay, so I really like this guy. So apparently, headaches are not something new. I don't know where this is, but I really liked it. So nomenclature. So I just want to have a few words about nomenclature, just because people get confused about what's what. So what is defined as chronic? So as a general rule, okay, there are a couple of exceptions, including cluster headaches, but as a general rule, chronic is defined as more than half of the days in the month and more than 3 months. So a kid who's been having migraines for more than 15 days in the month, and it's been going on for more than 3 months, gets a diagnosis of chronic migraine headaches. A kid who's been having daily headaches, in other words, headaches that are occurring more than 15 days per month, and it's been going on more than 3 months, does not meet the criteria for migraine, is going to be diagnosed with something called chronic daily headaches. And very often I will see patients who will have a combination of 2 or 3 different diagnoses. An aura. An aura is something that is also often misunderstood. What is an aura? An aura is, most of us understand the typical aura, which occurs usually a few minutes before the headache, and is associated with visual, sensory, speech, or motor symptoms. The ones that we're all familiar with is the visual auras. Those really fall into two categories, the positive and the negative auras. The positive auras are the photopsia, which is those spots or those zone-formed lights, or the fortification scotoma, which I'm going to show you an example of in a minute, which is really those wiggly lines that form in front of the eyes are very bizarre. The negative auras, the negative visual auras are the scotomas, which are most frequently seen in bipolar migraine. But you can have sensory. Sensory symptoms are incredibly common. So paresthesia, tingling, numbness on one side of the body is characteristic. Now, note that on all of these, for the typical migraine, they're unilateral. Speech can be affected. Most of migraineurs will tell you they may have difficulty up to a day before the migraine. They just start developing speech. They have a difficulty. They have a sensation. They have difficulty getting the words out. And in fact, it can outlast that migraine by up to 24 hours. And motor auras are classified as hemiplegic migraine, which we're not going to talk about today. But it's important to notice that, to know that they exist, because those are the kids you're going to see in the emergency room, and you're going to think about a stroke. And if there is a doubt, you really should get the CT and make sure that's not what's going on. But typically with the motor aura that is associated with the hemiplegic migraine, it's going to be a gradual onset as opposed to the sudden onset that you see with stroke. So again here, the key is all of those symptoms develop gradually, and they typically resolve over 60 minutes. Note that the premonitory symptoms, which we briefly talked about, can last up to 2 to 24 hours. And all of these are fully reversible. Status migrainosus is a migraine that lasts more than 72 hours. By that point, the child will be in the hospital and under my care. And we'll briefly talk about how I manage these.
Is it possible to get these auras and then not develop a headache?
Yes. So we're going to come back to that. That is actually a form of migraine. It is
for like optic or
yes.
ocular migraines.
So ocular migraines are incredibly rare, but there is a form of migraine that is the migraine with aura without a headache, which is actually much more common and will freak people out. In fact, just about a month, I have a long history of migraine. I'm a migrainer myself. And just about a month ago, I wake up and I was fine, and within 15 minutes of waking up, I have this very bizarre sensation of this shiny shower coming down in my left visual field. And I did not connect 2 and 2 together. And I'm like, what is going on? And of course, from a neurological point of view, I could not make any sense of this. I knew this was not a stroke. It just didn't fit. And so, I'm walking into work, and as I walk into work, I turn toward our colleague, Jen Bickel, who is our migraine expert, our headache expert here at Children's Mercy. And I tell her, Jen, I've had these funny things going on since I woke up this morning. And she looked at me, she smiled, and she said, Jippy, that's an aura. And, and it is very bizarre, because, in my case, it was in a hemi field. It lasted about an hour. It resolved, and there was no headache associated, and I have never had that. So it will catch even the expert by surprise when it happens to him. Which is funny. If I had heard it in anybody else, I would have said, that's an aura. But, we're the worst at diagnosing ourselves. So, yes, absolutely. That does happen. We're going to get back to it in a second. So, this is the fortification scotoma. This is actually from a book that was published by Sir William Gower in 1907. And it is a patient who is drawing his fortification. So, this is the type of thing that a patient will typically see. Okay. So just a brief parenthesis here, I could not resist say a couple of words of migraine through the ages. So supposedly Ezekiel maybe had auras, since we just talked about auras, or who knows, some of his visions are, some people have speculated auras. Hildegard von Bingen, which is Saint Hildegard, is a very famous Benedictine nun in the 12th century who had these visions, And so this is Hildegard von Bingen, who is dictating her vision to her scribe. And you can see sort of falling in front of her this curtain that really looks very much like an aura to me, the way that it is depicted. And here is some of the art. So she's very famous for her artwork. Here is some of her art, and you can almost see the aura in this. I mean, it has this very typical characteristic. So again, this is all speculation. We don't know this for sure. Lewis Carroll is also speculated to have suffered from migraines, and in fact, there is a syndrome which is called the Alice in Wonderland syndrome, which will frequently occur with migraines, but can occur with a lot of different things, and which is basically micropsia and macropsia. So everything will appear much smaller, or everything will appear much bigger. That will also occur in children when they have night terrors, and it will terrify the parents. So that is Alice in Wonderland syndrome. And then trepanation, just a word on trepanation. There are speculations. Clearly trepanation was used in the Stone Age. We have very good evidence that it was used. We don't know what it was used for. Based on some drawings, some people speculate that it may have been used to treat migraines. Certainly in the Middle Ages, there's some very good data that trepanation was used to treat migraine headaches. So these are some, it doesn't look good, does it? Okay. So that was just a little parenthesis. I just couldn't resist. Migraine headaches, so epidemiology. So we're not going to talk about this type of headache.
Is that guy a Klingon?
I don't know what that's from. I don't have a clue. But so I want to talk a little bit about epidemiology, because I think one of the things that we don't realize is how common migraines are. So migraine epidemiology. So just a word, okay, I apologize. I hope I'm not insulting anybody, but I need to remind myself the difference between incidence and prevalence every single time, okay? So incidence is the number of events over a defined period of time, and prevalence is the proportion of the population that has the disease over a given period. In other words, another way to work that is incidence measures the temporal increase in disease burden, while prevalence measures the overall disease burden. This is important to keep in mind as we look at the next couple of slides. So incidence. And here are some of the points that I want to make that are important, is that migraines occur in children, okay? And in fact, in children less than 10 years old, they will be more frequent in male than female. And I didn't put the numbers in because those numbers don't make any sense to me, but the numbers are anywhere from between 6 and 10 per 1,000 patient year. I can never make sense of that patient year, but for those of you who do, that's typically what it is. Little girls are going to be around 6, little boys are going to be around 8. In adolescence, the trend reverses, and the females will greatly exceed the males, and that is the trend that is